Thank you, Dr. Eads. We are excited by this progress in immunotherapy. Our next speakers are going to talk about recent advances that have gone from bench to bedside. Doctors Andy Liao and Abdul Khan are from University of Chicago Medicine. Dr. Liao is co-director of the Neuroendocrine Tumor Program and an associate professor of medicine. He leads many clinical trials. Dr. Khan is an interventional radiologist and assistant professor of radiology.
Hi, I'm Andy Liao, and I'm a medical oncologist from the University of Chicago. Today, I'll be talking about recent advances in systemic therapy for neuroendocrine tumor patients. So, in our brief talk, we'll talk about cabozantinib, which is the newest FDA-approved treatment, and alpha particle PRT, a novel PRT strategy. Let's start by reviewing the systemic therapy landscape for well-differentiated neuroendocrine tumors. For first-line therapy, we typically use somatostatin analogs such as octreotide or lanreotide. When patients progress on this, then for second-line and beyond therapy, we have PRT. The FDA-approved one is lutetium dotatate or Lutathera. This drug also has efficacy in the first-line setting, and we'll talk about some of the newer PRT approaches such as alpha particle PRT. We also have targeted therapies, including everolimus, sunitinib, and cabozantinib, which we'll talk about, which is the newest FDA-approved treatment option. And we also use conventional chemotherapy, such as capecitabine and temozolomide, for pancreatic neuroendocrine tumor patients. So let's start by talking about cabozantinib. Before we go into the data for cabozantinib, this is a summary of the currently FDA-approved targeted therapies for well-differentiated neuroendocrine tumors, which includes everolimus and sunitinib for pancreatic neuroendocrine tumors, and also everolimus for GI and lung neuroendocrine tumors. All of these agents are approved based on phase 3 clinical trials showing a progression-free survival benefit, with a progression-free survival around 11 months versus 4 to 5 months in the placebo group. These agents tend to keep the tumor stable rather than really cause significant shrinkage, response rate of only 2 to 9%. So cabozantinib is a new targeted therapy that targets many pathways, including the VEGF receptor, MET, and AXL. And what it does is it stops the tumors from making new blood vessels, stops them from hiding from the immune system, stops them from growing, but also invading. Cabozantinib was studied in a phase 3 clinical trial called the CABINET trial. This study enrolled 298 patients with advanced neuroendocrine tumors, randomized in 2 to 1 to getting cabozantinib 60 milligrams daily versus placebo. Those patients in the placebo group can cross over to get real cabozantinib at the time of disease progression. So let's start by focusing on the cohort of pancreatic neuroendocrine tumor patients. There were 64 patients treated with cabozantinib in this cohort. So the median time from diagnosis is 71 months, so this is later on in the treatment journey. Patients have had 1 to 9 prior lines of systemic therapy, so heavily pretreated population. Prior lines of therapy included PRT, everolimus, sunitinib, or capecitabine and temozolomide. And these patients had grade 1, grade 2, or grade 3 tumors, 22% grade 1, 61% grade 2, and 13% grade 3. For pancreatic neuroendocrine tumor patients, cabozantinib quadrupled the median progression-free survival compared to placebo, with a median PFS of 13.8 months versus 4.4 months, and a 77% reduction in the risk of progression or death. The response rate of cabozantinib was 19%, which compares favorably to everolimus' sunitinib, as I showed you in the previous slide, of the currently approved targeted therapy agents. The overall survival wasn't significantly different, but keep in mind that this is premature data, and the trial also allowed for crossover, which always dilutes the overall survival benefit, so we need longer-term follow-up for this data point. In terms of subgroup analysis, you can see that cabozantinib benefited regardless of the tumor grade, prior everolimus, prior sunitinib, prior PRT, or whether the patients were concurrently on a somatostatin analog. Now let's focus on a cohort of patients with extrapancreatic neuroendocrine tumors. So this included 134 patients treated with cabozantinib. Again, this is later on in the treatment journey. Median time from diagnosis was 65 months. These were also heavily pretreated patients, a range of 1 to 6 prior lines of systemic therapy agents, including PRT, everolimus, and chemotherapy. And again, this cohort of patients had grade 1, grade 2, and grade 3 tumors, 28% grade 1, 64% grade 2, and 6% grade 3. If you look at the site of origin, most of these patients had GI origin tumors, but also lung primary, thymic primary, unknown primary, and other primaries. For extrapancreatic neuroendocrine tumor patients, cabozantinib doubled the median progression-free survival with a median PFS of 8.4 months compared to 3.9 months in placebo, translating into a 62% reduction in the risk for progression or death. The response rate was only 5%, keeping in line with the other approved targeted therapy options for this patient population. Their survival was again similar, keeping in mind that this is premature data and the study allowed for crossover. If you look at subgroup analysis again, so it seems that cabozantinib benefited these patients regardless of the site of origin of the tumors, regardless of whether it's GI or lung or thymic or other primary or unknown primary, regardless of tumor grade, and then regardless of whether they were concurrently on a somatostatin analog, and regardless of whether they had prior everolimus or PRRT. What are some of the adverse events that we see with cabozantinib therapy? Well, the most common ones include fatigue, diarrhea, and hand-foot syndrome. Otherwise, there's no really any new safety signals other than what we already knew about cabozantinib in its other approved indication. The one thing that caught my eye was the increase of blood clots in the patients with pancreatic neuroendocrine tumors, so something to keep in mind. If you look at the median average daily dose, so keep in mind that everyone in the cabinet trial started at 60 milligrams of cabozantinib, but they invariably needed to have dose interruptions or reductions based on side effects. So the median average daily dose in the extrapancreatic NET cohort was 38.4 milligrams, and for the pancreatic NET cohort was 37.9 milligrams. So to summarize, cabozantinib significantly improved progression-free survival in well-differentiated neuroendocrine tumor patients and became the newest FDA-approved systemic therapy options approved for patients who have progressed on one line of prior therapy. We see the benefit of cabozantinib regardless of the site of origin, regardless of tumor grade, and regardless of which previous therapies these patients got. It's active even in patients who have been heavily pretreated and have received many prior lines of systemic therapies. The side effects are consistent with what we already knew about cabozantinib, no surprises there. And what do we do? Where do we sequence cabozantinib in our treatment? Well, in our practice at an academic center, we tend to give it after PRRT. But technically, this is approved for second and beyond therapy. So in the community practice, where patients may not have access to PRRT, they may give it after first line and rheotide or octreotide. Now we're going to move on to talk about novel PRRT strategies. So we all know that lutetium dotatate PRRT is the cornerstone of systemic therapy for neuroendocrine tumors. This is another one study showing that lutetium dotatate significantly improved progression-free survival versus high-dose octreotide, and also improved the response rate. And there was also a numeric trend towards improvement in overall survival. There's also other data showing the benefit of lutetium dotatate in lung and pancreatic neuroendocrine tumors. And therefore, when the FDA approved lutetium dotatate, they approve it for second and beyond therapy for somatostatin receptor expressing GI and pancreatic neuroendocrine tumors. There's also data for using lutetium dotatate in first-line therapy, as shown here, the NETRF study showing that it improved progression-free survival and response rate. But how do we do better with PRT? So one new strategy, what's called alpha particle PRT. Alpha particle PRT uses alpha particles such as lead and actinium, which compares to lutetium, which is a beta emitter used in conventional Lutathera. And the theoretical advantage of alpha particles is it has a short range that allows for selective targeting of the tumor cells while sparing the surrounding healthy tissue, and there's higher energy transfer compared to beta emitters. So alpha particles can cause more double-stranded DNA breaks, increased generation of reactive oxygen species, increased bystander effect, and increased immune activation, all of which should cause for more effective tumor cell killing. So how does this translate into clinical data? Shown here is results from the phase 1 and 2 Alpha Medic 01 and 02 clinical trial. This is the largest presented data for alpha PRT. This is lead dotamtate in a cohort of patients who have GI and pancreatic neuroendocrine tumor patients who had never received PRT. And there were 44 patients in this cohort. The response rate was 57%. The 24-month progression-free survival was 74%, and the 24-month overall survival rate was 91%. You can see here in the right-hand side of the slide, a patient who responded remarkably well to this alpha PRT drug. In terms of side effects, there's no substantial hematologic toxicity. We saw grade 3 and grade 4 lymphopenia that was largely reversible. There was also mild to moderate hair loss that was transient. And then there's dysphagia from achalasia. So these patients, for unknown reasons, had difficulty with swallowing. There's also a different cohort of this same clinical trial looking at patients who have already gotten PRT in the past. So shown here is a patient who was treated with alpha PRT with lead-dotamtate after previously progressing on lutetium dotatate. You can see that this patient had a great response to alpha PRT following previous beta PRT. So we need to wait until the cohort enrolls to see what the data looks like, to see how active is alpha PRT following beta PRT to tell us how to sequence these two treatment options. A different alpha PRT drug is called lead VMT alpha NET. So shown here is the first reported outcomes in the phase 1 clinical trial with this drug for PRT naive neuroendocrine tumor patients. So in these 9 patients that we have data on, the response rate was 44%, so 4 out of 9 patients, and the 12-month progression-free survival rate was 78%, so 7 out of 9 patients. You can see here on the right-hand side of the slide, a patient who responded very well with significant shrinkage of the liver tumor 48 weeks into treatment. In terms of side effects, this tends to be very well tolerated. There were no dose-limiting toxicities or grade 4 or grade 5 toxicities. There was no dysphagia or any serious kidney complications. The most common side effects are diarrhea, decreased lymphocyte count, and increased creatinine. So where does alpha PRT fit in our practice? Well, when we talk about novel PRT strategies, we talk about different types of radioisotopes, alpha versus beta. We talk about individualized dosimetry, so using the tumor burden and tumor uptake to guide the dose that the patient actually gets. We talk about PRT retreatment and combination strategies, expanding the current indications of PRT, so beyond the low-grade GI and pancreatic neuroendocrine tumors to other indications and also to patients with grade 3 tumors. And finally, we talk about treatment sequencing. So is alpha PRT better than beta PRT? Should we use it first or should we reserve it for patients who progress on beta PRT? And how do we fit PRT in amongst the other new systemic therapies that are coming on board, such as cabozantinib? So the final verdict for alpha PRT, where it fits in our practice, is that it's too early to tell. We need to wait for further clinical trial results to give us more information on how we use alpha PRT. And to that end, here's a list of ongoing PRT trials, looking at alpha PRT, but also looking at retreatment, combinations, individualized dosimetry, and etc. And for all our neuroendocrine tumor patients, I highly encourage you to seek out and participate in clinical trials because this is how we make progress in our field. You could help yourself, but also other neuroendocrine tumor patients like you. Thank you for joining us today.
Hi, I'm Abdul Khan. I'm a relatively new faculty member at the University of Chicago within the Interventional Radiology Department. I just started last August, and I'll be presenting about neuroendocrine and tumor and the use of histotripsy. I have no relevant disclosures. So what is histotripsy? Histotripsy is a non-invasive, non-thermal ionizing form of energy that allows us to produce mechanical disruption in tissues. The way we do this is we administer pulse sound waves to create microbubbles, utilizing those sound waves. And these microbubbles ultimately destroy the tissue. They liquefy the tissue. The nice thing about it is that they perform a uniform treatment, and they also spare some of the collagen-containing structures in the liver, including blood vessels and bile ducts. Here we can see a video of those microbubbles circling the tumor and liquefying the tumor as those microbubbles go throughout the entire tumor. The potential of histotripsy can be curative or definitive in its treatment. Usually liver lesions that are 3 centimeters or less can be treated completely in one single session. But past trials evaluating histotripsy, including Hope for Liver, did include 2 neuroendocrine tumor patients that were treated. It can also be utilized in combination therapy in a sense of downstaging or debulking liver lesions, further treatment, including surgical resection. The other potential is immunostimulation. Histotrypsy alters tumor biology to sensitize tumors to immunotherapy by releasing tumor antigens, and this may help generate an immune response. The procedure itself is performed under general anesthesia. Typically, paralysis is required to minimize any movement during the ablation. There's a water bath that's centered over the patient, and that allows sound waves to travel through the ultrasound machine, through the skin, and to the target tissue. The machine itself is then positioned with the treatment arm over the water bath to target the tissue. Most of the procedure time occurs during the planning of the treatment. Once everything is planned, the actual treatment itself takes around 20 minutes. For larger lesions, it may take a little bit longer, 40 minutes. We typically perform this outpatient. After the patient wakes up from anesthesia, they're observed for a couple hours before being sent home. Post-procedure, usually minimal amount of pain or soreness, maybe some mild nausea lasting about 24 to 48 hours. Otherwise, the procedure itself is very well tolerated. Limitations: it is necessary to visualize lesions or target tissue under ultrasound. And so lesions that are covered up by air-filled structures such as lung or intestines may not be amenable to histotrypsy. There are also some depth requirements. And then there may be some obstruction from overlying bone or cartilage. Performing histotrypsy to tissues beneath these may require higher voltage. There's possibility that the energy sent to the target tissue has reduced energy, and then there's potential for some thermal injury to those bone or cartilage structures. So here we go through a couple case examples of histotrypsy. First patient is a patient with small bowel neuroendocrine tumor on lanreotide and had progression of liver disease. Here we see a pre-treatment MRI of our lesion. Immediately post-procedure, CTA was performed in this patient, and we see sort of swelling of that tumor and some surrounding rim hyperenhancement indicating hyperemia, the inflammatory response going to that tumor. And 6 to 7 months post-treatment, we have a PET-CT showing no activity in the area that was treated, and a 9-month post-MRI scan showing significantly interval decreased size of that lesion. Here we have another example of histotrypsy in a patient with a pancreatic neuroendocrine tumor, once again on a somatostatin analog with MRI showing progression of liver disease. This patient had a lesion in their liver that was adjacent to their kidney. We took a look of that lesion under ultrasound in our clinic to make sure that we would be able to perform histotrypsy on this patient. And so here are some intraoperative images of the actual histotrypsy ultrasound evaluating that lesion. Here we can see a sort of a well-encapsulated round structure corresponding with our tumor. When we do histotrypsy, we are able to pull MRI or CT scans of the patient and actually fuse them on top of the histotrypsy images to ensure that everything is aligned correctly and that we're able to ablate all of the tumor in its capacity. Here we have an action shot of the microbubbles in the center of that area. You can see there's some white coloring that it refers to the gas or microbubbles being formed in the target tissue. After this procedure, we did a post-ablation angiogram, and you can see multiple hypervascular tumors here. But notice that in the area that we performed histotrypsy, there's almost a burned out appearance or cleared out appearance of that tumor. We still see blood vessels going to that area, but the tumor itself has been obliterated. Our post-treatment MRI obtained 6 weeks later shows interval decrease in size of that tumor as well as decrease enhancement. Over the course of time, this will continue to decrease in size and involute. Histotrypsy is a great option. Certainly, all patients are screened very carefully, as not everyone is a candidate for histotrypsy. And with it being a new technology, something that we are still actively studying, but we're happy to offer it here at the University of Chicago.